All right, well, hello and welcome everyone. It looks like we already have a large number of attendees that are joining. I want to welcome you all to another Minnesota HIMSS webinar. Today we're going to be covering nursing informatics within the COVID environment, and we have an awesome panel of nursing leaders who are going to be talking through both their experiences as well as their overall organization strategy. Just a few reminders before we get going with the panel. So first of all, we are recording this event, and it's available to all HIMSS members after the fact. So if you're interested in either sending this to a colleague or watching another part of the discussion again, that will be emailed to you within a pretty short period of time after today's webinar, and that link is available to anyone to watch. We'd also like you to know that we have these webinars occurring a few times a month at this point, and if you're interested in either being a speaker or a sponsor for any of those future webinars, or just interested in seeing the calendar of webinars, you can head to mn.himschapter.org in order to learn more. We are going to be doing both a Q&A of some prepared questions as well as some of your questions today. So if you have any questions for any of the panelists, feel free to go ahead and put that in the Q&A box within GoToWebinar that sits on the right-hand side, and it's called questions. So just type in your question and we'll be monitoring them throughout the webinar and probably going through a fair number of your questions all at the end. So with that in mind, I'm going to hand things back over to Michael Zimmerman, who's going to be moderating today's panel, and he'll introduce the rest of our attendees as well.
Good morning. My name is Michael Zimmerman. I'm an IS nurse from Allina Health and a member of the board for the Minnesota chapter of HIMSS. And once again, I'd like to welcome you to this morning's panel discussion, or this afternoon at this point. Nursing informatics in a COVID environment, where are we and how did we get here? Everything has happened so fast in these last 5 to 6 months. So I'll be facilitating today's discussion, and Alex, as you met, is the magic behind the technology and will be assisting in monitoring the questions. And we thank him, because while, at least for me anywhere, I feel comfortable in technology, it is definitely a very narrow window of comfort. And when you start expanding beyond an EMR, yeah, not so expert. So technology is full of many surprises. As a reminder, the objectives for today's session were to discuss the unique challenges of technology implementation during a pandemic, which crossed many, many, many types of technology, and the implications that had for education and support. Identify the key roles in an agile clinical and nursing informatics team played in response to the pandemic, and identify the methods and challenges of involving and then educating the nursing staff. But I want to begin with the reason we're here and have the panel do brief introductions of themselves. And let's start with Becky.
Thanks, Michael. Yeah, my name is Becky Kohler, and I'm the director of the Informatics and Analytics Department at Hennepin Healthcare. As many of you are aware, Hennepin is in the heart of Minneapolis. We have one hospital, and then we have multiple clinics throughout Hennepin County, and also community services also throughout Hennepin County. We are a safety net hospital, and that has brought, of course, some unique challenges for us as well during this, which we'll talk about a little bit today. And our team of informatics is about 18. We have both our informatics team, which is made up of nurses and non-nursing people without a nursing background, and also some educators. And I'll hand it off back to you, Michael.
Laura, go ahead.
Hi, this is Laura Vanguard. I'm the Director of Nursing Informatics at Allina Health System. Allina Health System is made up of a lot of hospitals and clinics within largely the metro area, as well as part of western Wisconsin. We have a very small but evolving and growing informatics program at Allina. We are lucky with a lot of talent, and Michael is one of them, of RN analysts, but we are slowly growing and expanding our definition of what health informatics means at Allina. So we right now have a group of health informaticists on our team, about 4, and we also do a lot of partnership with our improvement system and analysts.
Thank you. Next, Sharon.
Thank you, Michael. So I'm Sharon Kirby, Chief Nursing Informatics Officer for Mayo Clinic. Mayo expands across the country. We've got Arizona, Florida, and Rochester, Minnesota, are destination medical centers where patients frequently come from all over the world. So we also have our community practices throughout Minnesota and Wisconsin, and some clinics in Iowa as well. So we have a diverse population. I do have a large informatics team. They are both nursing and clinical informaticists, and all in, it's about 115 on the team. So they I lead the team across the enterprise.
Thank you. And Terry? Terry, you want to take a moment and introduce yourself? Terry, are you hearing me? Is anyone hearing me?
Yes.
Terry? I don't see your mic muted.
Based on the fact that she's so still, I'm guessing that maybe her system.
Oh, she's waving her head back and forth. Alex, can you reach out and see if we're having technical issues with Terry? And when we get her back, we can perhaps have her introduce herself and speak to a question. So to kick things off, what I'm wondering is, how did the work of your nurse informaticists change during the pandemic? What role did they play in that response? So what was the work like for them before, and how has it changed? And I'll just let anybody jump in. Lottery, Sharon.
So I would say for our informaticists, a lot of the work that was done during the pandemic was traditionally work that we do. I would say there was a lot of illumination on the skill set of the informaticist, the need for informatics when you are trying to implement something quickly, safely, and really stay focused on standing up a quality outcome, getting the informaticists involved at the front end, and how important that is. And so, initially that wasn't the response, but quickly people realized that they needed them at the table. And so we were a part of the incident command centers at all of our sites. We developed the COVID workflows. We ended up with about 9 COVID workflows, very complex, only 9. It seems as though there were more because there was a lot of work around that. Building out navigators so that we could decrease documentation time, both for the ED. We did a pandemic navigator as well as a disaster navigator for inpatient, with surge planning and having to ensure that the build, we're on Epic. I think we're also on Epic for your medical software vendor, and just the facility build that was needed. Quickly, the sites realized they needed access to be involved as they were trying to plan out the surge planning and ensure that we were building in alignment with the EHR. We helped with retraining for those roles that were at the departments that were closing, and then ones that were ramping up. So on ambulatory or surgery, those type of roles where we helped build curriculum, abbreviated curriculum, so that people could function in another role. So we had a lot to do with that. And partnered with infectious disease on a lot of the reporting. And then we were in the labor pool, not so much in the Midwest, but we did have to pull some informaticists into some COVID swabbing and screening and things like that, especially in Arizona and Florida when we were having a big surge there.
Thank you. I see we've got Terry back. Yes. Terry, are you connected? Can you hear me? Okay, still working on that. Laura or Becky, do you have anything to add for that? How it changed, how the work changed and the role they played in the response? Laura?
Yeah, this is Laura. I can chime in. I think, again, can you hear me?
Yep.
Mm-hmm.
I think for us, similar to what you said, Sharon, it put us on the front end of kind of the requests and the challenges. I think both for medical informatics and for nursing informatics, kind of being at the position where we were receiving kind of the initial requests and trying to vet them quickly clinically so that we can move into action faster. So I think for us, it helped change a little bit of our decision-making process within IS, at least with respect to COVID requests. The other place that nursing informatics, I think, played a pretty critical role was thinking about how we were going to adapt and adjust our documentation. We used MDH's crisis model to think about how standards of care would change for nursing should we arrive at that crisis state. And then based on those standards of care, we iterated our documentation flow sheets in a way that was, I think we reduced about 200 rows in order to really streamline how nursing might document should we arrive at kind of that crisis documentation. So we played a lot of role in thinking about the how work could happen and making sure that it was clinically aligned. And then we also thought about the ways we would communicate and educate. We did do some education and awareness that this documentation would be out there and available for nursing should it be needed. But I think I was blown away at how quickly we could iterate our documentation when we really needed to. So I think it will hopefully lead to a little bit of fast track, potentially of some innovation for us. That's my hope.
Thank you. Try again, Terry. Are you able to hear me and introduce yourself?
I am. Can you hear me?
Yes, I can hear you. So I'll let you, we'll back up a little bit and let Terry introduce herself and her role.
So I'm Terry Rachel. I'm the Director of Clinical Applications and Informatics at North Memorial Hospital in Robbinsdale, Minnesota. I've been a nurse for 33 years and got into the informatics and EMR arena about 16 years ago.
Thank you very much. So continuing on that theme for Terry and Becky, so the change to the nursing informatics role, but as Sharon mentioned, all four of you and us are on the same vendor product. Did at any point you find that beneficial across organizations, and were you able to reach out across organizations for discussion or how to configure or make decisions based on the vendor? Terry?
For us, things are moving pretty fast that I don't think we had, unfortunately, an opportunity to reach out to our peers as much as we normally do. I think in Minnesota, we have a really great relationship with all the other organizations when it comes to our vendor that we work with. But with the pandemic, things are moving really fast. I did reach out to one organization at one point, but it was pretty limited.
Becky?
Yeah, and I agree. It was hard to really carve out time for that normal reach out that we would do and sharing of ideas. I think that we received a lot of information from our vendor, and that was helpful. And I think a lot of us received probably the same information. We're probably all working off the same document, actually. And I'm pretty sure I had a conversation with Sharon at one point and some of the things that they were implementing, and I was like, yep, we're doing the same thing. I think it's really helpful to know that I can reach out. That's one thing I really I like about the Twin Cities and about this group of colleagues as well, is that if we were stuck, I knew I could reach out, and that's really helpful. I think that's unique for us and really beneficial.
So that said, we know that nurses, doctors, clinicians, all of that can't change where or how they work during a pandemic, but informatics crosses multiple roles and multiple work sites. So did you have to, or did you move any of your staff off site, and how did it impact your work? So Sharon?
So we did move our informaticists off site, and it was amazing the amount of work that they were able to do, the productivity, despite the fact that they were off site. Actually, Mayo had to move some 60,000 employees within 6 days off-site. Wow. Across 5 states, across 3 time zones, and it was just a phenomenal feat. So a third of Mayo staff was moved off-site in 6 days. So that was just incredible what they were able to accomplish with that, and still, you know, the work that we were able to accomplish in the productivity while still remote.
Terry?
We moved all of our staff off-site, all of our shared services, including all of the informaticists and IT department, were moved off-site in less than a 24-hour notice. And I agree with Sharon that the amount of productivity that they were able to do for us, with turnaround windows sometimes of a day, maybe a week at most, I was amazed and extremely proud of my staff on what they were able to accomplish.
Yeah.
Becky, Laura?
Yeah, I agree with what both Terry and Sharon mentioned. We did also move our staff off-site. We do have some people coming in for onboarding classes and some project go-lives where we just really couldn't do it without being there with the staff. And but yeah, the productivity has remained, and I think that some of the challenges that we see with being off-site or with communication and being able to really connect, we've actually we've learned a lot. I mean, I feel like I just have been impressed at how people have adapted and have really worked to maintain relationships and collaboration despite being not together. So I think that's been really good.
Sounds good. So what did the COVID, or not so much COVID, but as well as pandemics that have to do everything so quickly, what did that reveal about your nursing informatics program? Laura? Laura, to start?
Yeah, sure. So I think one of the things that it revealed is that when we're really aligned on purpose and challenge, we can really move fast. And I think one of the things, you know, one of the opportunities of COVID is that there was complete clarity of purpose. You know, what we need to do now is support the teams, to support the patients, to support the community. And so it cut a lot of the, I don't want to use the word politics, but some of it is, you know, sometimes there are personal attachments to different ways of doing things. And I think in this case, everybody kind of set that aside in terms of stakeholders and just enabled us to really problem solve fast. So I think that was a huge gain and really did enable us to work fast. I think we also gave up on perfection a little bit, and we followed, the 80-20 rule a lot closer than maybe we do in every day. So I think those were some of the observations that I had.
Anyone else?
Yes, Laura, I would say don't let perfect get in the way of good or good enough was definitely the mantra of the day every day, that we had to be very agile. And for us at Mayo, I think we're impacted a little bit differently because when surgeries were stopped and outpatient visits were stopped, so many of our patients are travel from around the country, around the world to see us. So we felt the financial impact probably sooner than others did. And so we had, on top of trying to coordinate around getting the work done that needed to be done around COVID, we had, financial restraints as well, reductions to put into place, furloughs, reduced staffing. And so within 4 days, had to come up with a plan of how over a 4-month period you would furlough 40% of your staff and still get the work done, and know which projects would go on, which ones would be on hold, and know which skill sets to keep and which would go. And the amount of camaraderie and teamwork, the furloughs, I didn't have to furlough any of the staff; they all volunteered, and they really did it to help the rest of the staff. And then the ones that were left had to do roles that they were not accustomed to, maybe cover ambulatory when they only are familiar with inpatient, or a different application that they don't normally cover. But it just really showed the resiliency and how nimble and agile that they can truly be. So they were just amazing.
Yeah, I would echo that. I was amazed at the flexibility. That was really the key, and people stepping up into things where, no one said that's not my job. And we're certainly sometimes put in situations where, well, it's really not quite fits into our role, but people just stepped up and did it. Just people did what they needed to do. And I think, as Laura mentioned, having that common goal and purpose really was key. Was very helpful to move things forward quickly.
The other thing that
go ahead.
I was just going to add, the other thing was, as far as my nursing informatics, I had to also plan on how to backfill them, because they were on the list of people if we got into a crunch situation where they would get pulled back to the units for the ED. And so figuring out how to not only furlough staff, but backfill my nursing informatics were some of the other challenges that we had to figure out.
So speaking of that as well, how did you, and start with Terry, how did you then look at, so as a nursing informatics program, how did you look at other projects that were in the pipeline or other projects that were being worked on? Because sometimes those across other applications or other departments and stuff, how did you determine, did you have a prioritization, or how did you determine what projects got put? Of course, COVID pandemic, number one. How did you though figure out, or were there other projects that got continued in spite of or despite the pandemic? And how did you come up with that decision or ranking, Terry?
So really, our executive leadership helped with that. And probably out of all of the organizations, we're one of the smaller ones. And so we actually put all projects on hold. If it was not COVID related or break fix, it was put on hold. The only project that continued is we were in the middle of replacing our Philips monitors, and we did continue with that one and the integration within our EMR, but all other projects just got put on hold. And we just started bringing those projects back into production in June.
So I know, Laura, we had an update during that time, and we kept that project moving forward. Was that an impact? How did that impact you and your program and anybody else? Was that something that was also in your pipeline now that those are quarterly? So Laura, how did that impact informatics for us?
You know, I don't think for us it had a direct impact. I think that thankfully that's a process that that I think IS and Alina has really practiced, and it probably felt like one of the few normal rhythms the organization was experiencing. So in some ways it may have created a little bit of normalcy. It really didn't detract or take away from, I think, the work that we were doing. For other projects, similar to what Terry expressed, at Alina, most things held, you know, and whether that was a formal pause or an informal, you know, project leader saying, boy, this doesn't seem to be the right time to be focusing on this. I think we did have a lot of clarity that things that were not directly related or that wouldn't, couldn't be leveraged for the moment needed to wait. I think that what it did do is accelerate a lot of the activity we had been wanting to do in the tele and virtual space. I'm sure similar to everyone else. Those were things we'd all been wanting to get moving faster, and we flip-flopped and obviously fast-tracked a lot of that activity and started pulling back on those other projects.
What else did anybody else see as far as new projects that may have gotten ramped up or escalated as far as telehealth, virtual health, new equipment, things like that?
Streamlining documentation.
Mm-hmm.
It's like the thing we probably all do all the time.
Yeah.
It's like the nursing informatics thing to do. And yeah, so that kind of presented us with an opportunity to really take a look at our admission navigator, for example, and really streamline that so that, you know, preparing for the surge or the surge that did happen, that documentation wasn't as much of a hindrance for nursing.
So I know at Mayo we had our 2030 strategy to cure, connect, transform healthcare, and we feel like we actualized our 2030 strategy in the last few months. So what's the best part though is that we did have an infrastructure in place, but just because of regulations and funding, as you all know, it just, you know, didn't really take off. But we have a connected care arm at Mayo that's really anything that's patient facing. And so we had remote patient monitoring in place, and we had telehealth in place, but really didn't have the volume. But we were up to average daily census for remote patient monitoring was about 350 patients that we were monitoring. Telehealth went from about 35 visits a day to over 3,000 visits a day with care anywhere and outpatient visits. We average now about 1,400 a day, so versus the 35 that we used to do. And the other thing that we stood up quickly was interactive care plans. So if a patient was more complex care, they would move into the remote monitoring realm, and if they were more low risk, we built an interactive care plan for COVID patients, and so that would be something where the patient would complete questionnaires and daily tasks and education and such. So so we were able to again to expedite that and really see the fruits of that much quicker than we would have seen in the past.
Carrie, anything?
No, I would pretty much agree with everything they said. The thing that we had to do, we were not very far down our tele visits, and so that really got fast-tracked and got implemented, including securing a lot of equipment. which was very challenging because, as I'm sure everybody's aware, monitors, headsets, everything just flew off the shelves. So securing the equipment was actually more of a challenge than setting it up from the EMR standpoint.
So to that kind of a thing, how did all of this impact your governance processes, not just across informatics then? Because it sounds like you had capital, you had acquiring. How does it impact your governance processes? So Terry, to start.
So we have a fairly robust governance process on a regular basis, and that governance process actually got pushed to the side, and we went with a HICS governance process during the pandemic. So we had a incident command center and medical branch center, and the medical branch really made all the clinical decisions around whether we were going to implement telehealth, a lot of the medication changes that were happening on a daily basis based on supply and the changes to the labs. And so all of that went through the medical branch, and then incident command really prioritized and ran all the governance for us during the first 3 months of this pandemic.
Yeah, I'd
Anyone
be curious
else?
if any of us actually kept our previous governance. I know we didn't. We had to also kind of set that aside and went with the HICS structure as well.
Yes, and I would say
So from that,
the change request process, as we enter requests into ServiceNow, and if it wasn't COVID related or patient safety, regulatory, or finance, it didn't get done. So very focused, and we did still use our governance model, but we met at our EHR governance team was meeting daily at one point, and then several times a week we were able to stream back, cut back to less meeting time, but just the focus on the work that had to be done, we were able to move things quickly.
So a question from the audience is, I'd like to know if during the COVID response, if your organizations have uncovered inefficiencies or QI issues. Essentially, from a nursing informatics perspective, has the pandemic ultimately helped improve care delivery, patient experience, et cetera, in such a way that other areas might benefit once we're eventually in a post-COVID world? I throw that out to anyone.
Yeah, I can start. So as I alluded, we had 200 rows of kind of information that may or may not be adding value within our head to toe, as an example for nursing. And so though we've all kind of known and had instinct around that, this really enabled us to quickly quantify, to quickly articulate whether or not that was adding value from a patient safety perspective, and then make a decision about it. Not to say we would live with that crisis documentation the way we built it. That would never be kind of our end game, but it gives us a little bit of a crosswalk between what do we have now and what do we think is most critical to enable or ensure patient safety, and how can we find a way towards something better. So I think we absolutely identified that a lot of information has been put on the backs of nurses to gather and to collect and to store, and it's really taking away from their ability to be present with the patient. And so I think we could finally just really crisply articulate and quantify that. And so I think that's going to help us move forward.
Anyone else?
Another area that we addressed with our nursing informaticists was around dual sign-off with medications. So do all those medications that we were currently doing that dual sign-off, what is the real evidence around it, and do we need to do that? And we ended up decreasing the amount of medications that we go into the patient room and do that to RN sign off, just to decrease exposure. And that's something that once the pandemic is over, I don't know that we'll go back the other way, because as we looked at the evidence, we were probably doing more than we needed to do.
Mm-hmm. I would say at Mayo early on, all of the incident commands at each site was working a little bit more independently and coming up with workflows. And it was more of an afterthought that we're on a converged EHR and you can't create your own. And so, and I think the informaticists were great at being the voice of reason that we have to have more uniform. But of course, different sites had different resources on how they would support the various workflows. But just realizing that they had to be converged, I think that was a big lesson. And now, just after as the dust is settling a little bit, Mayo Clinic is really stepping back and looking at what we're calling the next normal, and who do we really need to have on site, and can people work from anywhere? And so there's a group that's focused on that now, to what's that going to look like, and what roles will stay remote, and what roles really need to physically be on site.
So, and then another question from viewers, people on the webinar. Again, encouraging questions so we can get them answered. How is onboarding of new staff being handled? Have you transitioned to remote training, or does that remain in person? Becky.
Yeah, I can start off. So immediately, kind of during the height of the summer pandemic, we had moved to all remote as an institution. New staff was given a laptop and login, and we were doing our classes remote. I would say it didn't last too terribly long for us before we started doing in-person classes. That was challenging. It's still, I think, kind of challenging because we have limits to the number of people who can be in a room together, and we have one nursing informaticist, although it's now more of a shared responsibility, doing those classes, and obviously one person can't be in two different rooms at the same time. And so we've kind of had to do some problem solving around that, and sharing the responsibility amongst multiple people, and getting our education team involved. And so, yeah, we started remote. There's still things that are remote. There's definitely things that are electronic. We've spent a lot of time investing in education materials and being able to have things available to staff, especially since some of the staff was, there was kind of a discussion around surge planning and redeployment of staff from one area to another. That was has been challenging to think about how to educate people across those lines as well. But yeah, we are starting to do more and more in-person education again.
So throwing into that, what you were saying, people being redeployed, what did those, I mean, because this was at the heat of the pandemic when everything was PPE and everything was so running so short. What was the response? How did some of the sites do the re-education? So if you'd only done OB for the last 20 years and suddenly things were changing there, how do you train that nurse, or did that nurse end up being redeployed to another area? How did you determine redeployment and then educate them for that redeployment?
Yeah, I can jump in. So I had the pleasure of being redeployed somewhat to that space. So in addition to the HICS structure, Alina stood up what was termed a planning command. So we had a secondary structure that was thinking about really the planning towards crisis or surge. And so that had different aspects, and one of them was workforce. So thinking specifically about how would we redeploy workforce from where to where. So if we've closed some of our clinics, how are we mobilizing that ambulatory nursing staff and to where? So what we did is we thought about the key positions, surgical services, ambulatory spaces, and we mapped them to likely clinical spaces that matched not only their skill set, but a little bit of their comfort. Like, how does that environment and skill set line up? And then we developed curriculum and training paths for each of those crosswalks. So if I'm a clinic RN and I'm mapping, and I've been in the hospital in the last 5 years, I'm mapped to a medical surgical space. What does that curriculum and on-site training look like? And we had about a week's worth of curriculum for each of those nurses. And we did deploy a fair amount of that training in anticipation, based on the modeling we were getting. We did do a fair amount of redeploying and training, and that was a combination of virtual and using our learning management system and modules, as well as on-site preceptorships, at least 3 shifts. So again, surgical services, PACU, we had mapped to critical care to back up our ICUs. So that's CRNAs from the surgical spaces were going to critical care. So that's a little bit of how we were approaching that redeployment.
Well, and then also out of this came new departments that didn't exist previously, like our outdoor or drive-through testing sites. So what did the process for standing those look like as far as figuring out the staff, deploying the resources, any of the informatics decisions and discussions that happened around that? Anyone jump in again?
So, so I can just start on that. So I know for the informatics team, we were very involved in creating the workflows for those screening, and actually were on site when we initially stood them up to help troubleshoot as we would, run into issues and such. We also were very involved with there was COVID triage nurse line that again had a process and a workflow that we crafted and worked closely with the clinicians in what that process would look like.
Carrie, Becky?
I would agree with what Sharon said. Really, the informatics role was to figure out what that new workflow would look like from start to finish, and then help translate that back to the analysts to help build it out, and then also played a really integral role in the testing of it to make sure that it was gonna work.
Yep, I agree.
So then another one that came in, how is informatics helping you in managing your workforce in returning to work?
Yeah.
Anyone have any thoughts on that? Good idea, not rapid answers.
No, I don't. I would say
That's a really good question. I think.
Go ahead, Laura.
Go ahead, Laura. It looks like you froze for a moment. Nope, now we've lost your.
So I had to think about it. Oh, okay. That was a really good question, and I think the place that I see the informatics team working kind of the most diligently in terms of getting people back to work is really in our clinic spaces, and thinking about that right balance between our virtual visits and our in-person visits, and what do those workflows look like, and how many people need to be on site based on that ratio of in-person versus virtual. So I think that's where they're probably leaning in the most for our organization, and thinking about how people get back to work and what does the new normal look like.
Yeah, and I think at Mayo our challenge will be, when can informatics go back to work, and the importance of us being on site and understanding the workflows, and just really having eyes on the departments and those relationships with them. And so I would say that's one thing that really suffers when we are remote. So I do see a role for us wanting to go back to work. We're actually toying with the idea of how can we do some kind of remote rounding, sort of scheduled with some departments to check in to see how things are, so that we don't lose that connection with the customer.
And so then, given the high traction towards providing home care, how is informatics aligned with your organization's vision with respect to actually providing home care?
So I could start. So one of the projects that we did not put on hold during the pandemic was an advanced care at home project, where this was in Florida, and then subsequently in Eau Claire. It was went live in Eau Claire just this month. And the premise of a patient potentially being seen in our ED, and then being offered, if they fit criteria, being offered to stay at home, and we would provide care for them at home with a physician assistant or another allied provider in nursing care would supply equipment, all of the technology. And so it's an initiative that we have a partnership with Medically Home, and so that was something that we felt needed to continue that project, because we felt that it did actually flow into what we could use for COVID. And so it has been very successful in that regard. And the informaticists, I should say, so we had a command center and 74 workflows that we needed to create for that actual model. And the informaticists were very integral in that process, and will continue to be involved in that project going forward as we roll it out at other sites.
Very good. Anyone else? So another question to throw out there to everybody is, what, if any, changes are being made or retained? I would add retained to prepare for the second surge and or the upcoming flu season, because they may actually be on top of each other.
So one of the things that we've started looking at is changing some of the order sets in preparation for the flu season coming up, and making sure that we have that all in alignment.
Scary thing to think about, but.
This is Laura. We have, so we named some of the changes that we made in documentation, outbreak navigators and outbreak flow sheets. So we have those things hidden in production should we need to use them. If we experience a surge or if we experience high volume in the coming months. And to Terry's point, I think thinking about some of the order sets and refining some of the things I think that we've had out there that may not be as effective, because again, we had to move really fast. I think that's also kind of on our list of things to do right now.
I would say one thing that we're looking at is functionality for what they're calling, Epic calls cocooning. So if a patient comes in to be seen and they get their flu vaccine, that we can also vaccine a family member. And so that's something that we're working on in Mayo Clinic Health System right now in preparation for flu season.
So what would you say, another question from the viewers, what is the biggest challenge that the rapid movement to telehealth, televisits has created for informatics at your institution? Biggest challenge that the rapid movement created?
Bandwidth.
That's a good answer.
Bandwidth is what I heard. Sharon, Becky, you were both saying?
I was just gonna say that one of the things that we've been challenged with is a lot of the tools are in English. You know, we're a safety net hospital, and we have a lot of patients who don't speak English, and so making sure that we have equity in our tools and then the services that we're providing, I think has been a challenge. It's something that I think that our technology needs to catch up with, and there's a lot of opportunity there. And it's one of the other challenges, which I know that we haven't talked a whole bunch about, is educating patients on being able to use technology. That was one thing that we kind of ran into really quickly as we moved to more and more telehealth, is that we're having patients sign up through MyChart and doing these video visits, which was new for patients, for a lot of our patients. And so, and then we also did some video through our ED and through our inpatient video visits. And so now you have a patient in a hospital using an iPad, and then people are gowned up and they're, you know, and the patient is sick. And how do you then educate that patient? And does that fall to the nurse? Does that fall to like the informatics team? How do we help support that? Those were some of the challenges that we ran into. And I think we're continuing to work through.
Yeah. What I'll add, and I agree with everything that's been said so far, and I agree with your equity comments, Becky. I think that has been a challenge to make sure we're really serving our community wholly in the same way. I think the other thing that I observed is that we were ready with some technology before we understood some workflows. And so I think we implemented, one of the things that I thought Alina just did beautifully and magically was acquired devices for us really fast and got things organized really fast in order for us to manage PPE scarcity. And I think that was impressive. The downside of it was we didn't think about, well, how exactly are we going to use that in-room technology, and how exactly, you know, is that going to be different for each clinical workflow? And so I think that that's still something that we could utilize in the future, but we need to really understand, like, what problems are we trying to solve with it. But I agree, we're asking patients and families who may or may not be comfortable with this sort of technology to lean into it without any standby help. The only other thing I would add is the challenge in really providing patient and family-centered care in this moment. You know, patients need their people, whomever they define as their family, and I think it's been really hard in this moment to solve for that gap. You know, how are we making the patient and family feel connected and not isolated, I think is still something that we don't understand well, at least in the inpatient setting. And even in the virtual, how do you help ensure that somebody is listening with, there often be multiple people at some of these visits that we're offering. Are they getting what they need? Are their families there?
Sounds good. So we're down to our last 4 minutes. So I'm going to do a final closing round robin of what did you learn? What did you learn from this informatics standpoint through the pandemic and the planning that you would like to take forward with you in your career or in informatics or in governance moving forward? So I'll start with Terry.
I think my biggest takeaway was the resiliency that everybody was able to show, and that we can really truly accomplish a lot in a short period of time and in some really different circumstances, being remote. And I think if we can leverage that and harness that energy going forward, I really think we can do a lot in the informatics area.
Laura.
I don't think it was new learning, but I think I was just reminded of some of the talent that nursing has in this organizational system thinking space, and how we really are, I think, a group of clinicians who can rise in this kind of moment where a lot of complex, fast-paced decisions need to get made. I think that we should be at those tables because I think we know how to do that well, and I hope that this was a moment where, you know, we were evidence of that.
Becky.
Yeah, I agree with what was said, and I would add relationships are really, really important. Our relationships with our customers, our relationships with our staff, our relationships with IT, and just the relationship between clinical and revenue. And just I was able to see people coming together in a way that we hadn't really experienced before. And it was, you know, it was strange to say, but it was good to be part of that and to see that. And I would love to just carry that forward. I think we have started carrying that forward, and it's really good. I like that.
Sharon?
Just to see that there's no guardrails in the world of informatics, that there's no stopping the things that we could be involved in, should be involved in. And now we're involved with external testing of over 100 companies and businesses, and you know, I would never think informatics would have a role in that, but they have a big role in those workflows. So just they, you know, thinking out of the box, and they're very creative and have a unique skill set. So I think it's really highlighted what informatics can bring to a healthcare organization.
Thank you. So I want to thank you all again on behalf of the Minnesota chapter of HIMSS and our webinar series and projects. I'd like to invite Alex back on for any closing technology stuff. I know our panelists have agreed to, there have been continuing questions coming in, have agreed to kind of review the questions that we did not get to, and so perhaps be able to reply to you in our follow-up emails after the webinar closes as well. So try and get those answers to you. So Alex, any closing technology information we need?
Thank you, Michael, and thanks to all the nursing leaders on our panel today. This has been awesome. As Michael said, we'll assemble your questions as well as some brief answers to provide in a follow-up email. Just as a brief reminder, this webinar was recorded. It's going to be available in a follow-up email for you as well. And then just please keep an eye on mn.himschapter.org for all of our future webinar events. Thanks, everyone. Have a great day.
Thank you.
Thank you.
Thanks a lot.
Thank you, Alex.